Well, hello, everyone. My talk's going to be on catheter ablation in Ebstein's anomaly, and I hope you're all enjoying PedirhythmX 10. I have no conflicts regarding this topic. I'm going to start by saying that Ebstein's anomaly, for someone who does catheter ablation, is what they would refer to in the military as a target-rich environment. There's a lot of different mechanisms for tachycardia in this condition, the most common being accessory pathways, but there's also a high incidence of atriovesicular pathways. AV nodal reentry is more common in the general population, and a subset of these patients can have monomorphic ventricular tachycardia that usually arises from the atrialized ventricular muscle. It's also acquired arrhythmias such as IART, focal atrial tachycardia, in older patients, atrial fibrillation, and if ventricular function ever becomes too bad, or if there's left ventricular non-compaction, which is seen in a small subset of Ebstein's patients, there can also be polymorphic ventricular tachycardia. Incidence of sudden death, which is presumed arrhythmic from any of the above mechanisms, is variably calculated at somewhere between 8 and 16%. Given the time constraints, I'm going to confine my comments to accessory pathways today, which are not just the most common, but one of the most frustrating forms of accessory pathway in any condition I've ever been involved with. Back in the 1990s, the Pediatric EP Society put together a multi-center experience with accessory pathway ablation in Ebstein's anomaly. There were 39 patients, about half of whom had multiple pathways. Not surprisingly, these were mostly right-sided. And the acute success rate at that time was inferior to conventional accessory pathway ablation. Still not bad, but still inferior. But the most surprising thing was the high recurrence rate, roughly 1/3. Now, one could say that's early in our experience, that tools have gotten better, mapping's gotten better, ablation modalities have gotten better. However, an update in 2011, this is a multi-center European study from experienced good centers, 32 patients, not as many multiple pathways, all right-sided, and the outcomes had not changed all that much. 80% acute success rate and a 40% recurrence rate. So despite all the technical progress we've made, there's something biologically here that is still frustrating. And just to share our own dirty laundry, this is our institutional experience with Ebstein's anomaly going way back to the early days, but 78 pathways and 61 patients, mostly right-sided and mostly where you would expect them, where the tricuspid valve leaflets are most adherent along the inferior and septal leaflets. Our acute success rate, still not what we would like, and these are areas where we're usually really good at getting ablation success. These are usually not that complicated in a normal heart, but in these Ebstein's patients, only 89% acute success and still a 24% recurrence rate. A lot of these patients had multiple procedures. Some went for surgery and had surgical ablation. We finally got the success rate up to 94%, but it was a lot more work than one would have anticipated. So why is ablation so challenging in Ebstein's for accessory pathways? Well, there's three categories of hurdles that we have to get over. One is electrophysiologic, the other is anatomic, and the third, which is particularly relevant for neonates who can be quite sick with Ebstein's anomaly, made worse by recurrent tachycardia. There can be hemodynamic challenges as well. So let's start with the electrical challenges. First thing that you have to know is that you can't expect to see ordinary looking electrograms when you record along the AV groove. The AV groove contains the areas where there is atrialized ventricle, and as one would expect, the ventricular component is not as well developed as we're used to seeing in a normal heart. So this is a signal at the site of success for a 9-year-old. You can see that the ventricular component, despite the fact that we're right on the AV groove, is really quite diminutive in comparison to what we're used to seeing. There are a lot of extra little signals there, which may be accessory pathway potentials. It's not rare to see them. It doesn't always mean that it's going to be the successful ablation site, though. Here's another one where I'm not even sure where the ventricular signal was, and I couldn't tell whether this was an atrium, an accessory pathway, where's the ventricle. And what you really needed to do was get rid of the pre-excitation in order to see that. And you can do it with extra stimuli, but in this case, I'm showing the electrogram how it changes at the site of successful ablation. And I think that big signal in the middle was, in fact, an accessory pathway potential. Same thing when looking retrograde. This is during orthodromic tachycardia in a 3-month-old who had intractable tachycardia after initial stabilization. The complex signal at the site of successful ablation, we weren't really sure where the V stopped and the A started, but there was a clue during ablation. Here's where RF went on. You can see that the V and the A start to separate there a little bit, and finally you get retrograde block. But that's what the ventricular signal looked like. It's low amplitude, it's split in half, and despite the fact that we're right on the AV groove, the atrial component is much, much larger than the ventricular component. And that shouldn't surprise anybody. If you look at the biology of that area, this is a view of the diaphragmatic surface of the heart with Ebstein's anomaly. This is all atrialized right ventricle. I'm shining a light in here so that you can almost transilluminate how thin ventricular muscle is in that region right along the AV groove. It's almost like parchment paper. Another electrical challenge is that atrial muscle fiber orientation along the AV groove is really strange in some of these Ebstein's hearts. Here's one that has a big fan of atrial muscle coming off the true AV groove. Similarly in this one, and this is just showing a view from the epicardial surface of a big fan of atrial muscle. Those type of oblique fiber orientations are going to influence atrial activation patterns. And although you might record earliest atrial activation somewhere here, 2 problems: you're not on the AV groove, and you're not at the spot where you should be, which might be down here. So pay attention to atrial fiber orientation. As a consequence of all that, this is not atypical in ablation in an Ebstein's heart, where the blue dot is the site of initial success, sort of the posterolateral region along the tricuspid valve. We had to reinforce that with a lot of these smaller red dots, which you see here, because it kept recurring. And finally, a little bit more lateral to that, where the yellow dot is the site where we got final success. So despite precision mapping, you may have to paint a large area with RF applications to get the job done. Another electrical challenge is multiple pathways, which can be quite common. This is a case from years ago. It's a 21-year-old who had 4 right-sided accessory pathways. And I just show a clock face of his tricuspid valve here and the corresponding electrograms. They all looked great everywhere we looked, except fortunately for the His location, which is G. That was the only place where the V was late. Every place else, the V was early. And this was a very difficult procedure. This is one of the few cases where I resorted to putting a recording catheter in the right coronary artery. This is the old Cardima catheter, which we don't have access to anymore, but it helped us in this case localize the pathways a little bit better, but we still only got 3 out of the 4. We never got complete success in that case, despite 2 procedures. So the anatomic challenges, well, one's pretty obvious. RA tends to be enlarged. And a great example is this AP view here where we're injecting the right coronary artery. So here's the true AV groove. This is all right atrium here. It's humongous. What we find very helpful is doing an old-fashioned angiogram in the right atrium. It will often show you a little bit of a waste along the true annulus, and then a big pouched out atrialized right ventricle, and finally the mobile edges of the tricuspid valve leaflets. And obviously the site for ablation has to be on that true AV annulus to get rid of accessory pathways. Another anatomic challenge is what we refer to as the ridge. This is the internal view of the right atrium. It shows you where the coronary sinus is located. It shows you where the eustachian valve is located, membranous septum. This is the true AV groove here, and it's a big ridge of tissue. We're going to look at that in some other views. Sometimes that ridge is very sharp and thin. Sometimes it's more flattened but thick. And here's a cross-sectional view through the ridge. It shows you that the coronary vessels run in there. So that is the true AV groove. And histologically, this is a trichrome stain for connective tissue. It's a lot of fibrous tissue in there, not all muscles, a lot of fibrous tissue. And we got very lucky when we were looking at some of these pathology specimens. So here's the ridge. You can see the coronary vessels running through it. The ridge extends there, and we sampled right here. This is a patient where, when we looked at the autopsy report, was known to have Wolff-Parkinson-White syndrome. We did a lot of sectioning. We couldn't do too much because it would ruin the specimen. So we were allowed to take a chunk out here, and we got very lucky on serial sectioning because we found an accessory pathway. And I want to show you the relationship of that accessory pathway, or what we think is an accessory pathway, relative to the ridge. It's deep. This is the epicardial surface here. Here's the coronary vessel and the ridge. So the ridge would actually be up here, and the pathway is almost buried at the base of the ridge, which makes it more of an epicardial structure than an endocardial structure, and will increase the difficulty with ablation. Now that ridge seems to track with Ebstein's patients who have accessory pathways. When we looked at our pathology specimens, we divided them into patients with and without a history of either SVT or pre-excitation in life, and found that ridge was present in more patients who had accessory pathways than in the ones who did not. And that was the only significant difference between the 2 groups that we looked at. And we've now taken to use an ICE routinely in these procedures. This pink line here shows the extent of the ridge that we've defined. You can see a little slice with ICE through the ridge here. And we're not the first ones to, or the only ones to talk about this ridge. It's been known about for a long time. And the surgeons weren't surprised when we mentioned it. They said, yeah, we see that all the time. But these are just some other publications going back as far as the 1950s from Maury Lev. He talked about this ridge, which he called an intermediate bundle, between the atrium and the ventricle, and that's where he found accessory pathways. This is a image from the paper from Sanchez Quintana, looking at conduction system anatomy, in fact, and they point out that ridge, and you can see it in the big ridge in this case as well. So it's fairly common in Ebstein's, and it turns out that it occurs right at the spot where accessory pathways are most prevalent. And this just shows that you can identify the ridge tissue by looking for coronary vessels, as we saw in this example here. Another thing that we looked at when we examined the pathology specimens is whether there were any visible pathways. And we did find connections between that ridge and atrial muscle. And we were wondering if these were actually tissue that contained the accessory pathway itself. But that didn't sort out. That was seen in an equal number of patients with and without a prior history of SVT or known pre-excitation. Was not significant between the two groups. And I think that's probably just Chiari network and has nothing to do with the pre-excitation, which is more towards the epicardial aspect of the right atrium. Finally, there are anatomic challenges related to coronary artery injury. And there's competing concerns when you're ablating near that ridge. One, you would like to get the job done, but secondly, you don't want to hurt the right coronary artery. And I take this paper from Thomas Paul's group as an example. He's highlighting two coronary injuries, one in this postroceptal pathway. Well, that sort of makes sense. That's probably near the mouth of coronary sinus, and even in a normal heart, you have to worry about that. But this was more concerning. This was a posterolateral Ebstein's patient who had an ablation, and the right coronary artery was became quite stenotic afterwards. So our institutional policy is, despite the fact we know the ridge is there, we avoid irrigated RF. We use conventional RF under ICE guidance, but we ablate on the ridge and on both sides of the ridge, and we do that liberally. We also consider coronary imaging to make sure that we know exactly where that ridge is located, if it's there. And if we have to go into the coronary sinus, we would prefer to use cryoablation. So in mild Ebstein, sometimes when the leaflets aren't too adherent, we reinforce with RF applications underneath the tricuspid valve, if you can get the catheter there. And for infants, we tend to use a small catheter, 5 or 6 French, once again with concern for coronary artery injury. And then here is the hemodynamic challenges. This is mostly relevant for infants who tend to be hemodynamically unstable and made worse by arrhythmias. 5 of the 61 cases in our series involved these types of critically ill infants. And usually when they went into SVT, they became both hypotensive and increasingly cyanotic. 3 of these 5 cases had to be done on ECMO. And as I think everybody knows, using RF energy under ECMO conditions can sometimes be challenging as well. So I'll conclude by saying that in Ebstein's anomaly, accessory pathways are not what we're used to seeing in normal hearts. Defining the specific anatomy helps during ablation, and that can be done with any combination of angiography and ICE. Even in very small kids, we can put the ICE probe down the esophagus if their femoral vessels are too small to accommodate the catheter, and we could do imaging in that fashion. So be prepared for atypical electrograms and sometimes multiple pathways. And remember that recurrences will still remain more common than in a structurally normal heart. They will not infrequently require a second ablation procedure. And if the patient is going to the operating room, you may also want to consider having the surgeon reinforce the area with cryoablation. We're collecting data now to see if our outcomes have improved with directed imaging, and hopefully we'll have some updates soon. Thank you very much for your attention.